everybody. Thanks for joining us right on time. I wanted to say we're going to pull up our first slide, and while everybody's joining us, I want to plug our office hours that we're going to have this Friday at the same time, featuring the same two experts who are joining us this morning. Office hours is an opportunity to ask more specific questions about OpenNotes in a more informal group setting. I believe Deb is going to throw a link in the chat box right now in case you want to register for office hours. It's a more small, intimate setting. And thanks to Amanda, who's running the slides right now. So welcome to OpenNotes 101 for Clinicians with Dr. Sarah Jackson of Harborview Medical Center in Seattle, Washington, and Dr. Kate DeRoche, the Executive Director of OpenNotes. My name is Liz Salmi, and I am the Senior Strategist of Research Dissemination for OpenNotes, and I'll be introducing you to the cast of characters along the way. In case this is your first time joining us, you should know OpenNotes is not a product or software. OpenNotes, is proper noun, is a research team based at Beth Israel Deaconess Medical Center in Boston. As researchers, we've been studying the effects of shared clinical notes on patients, care partners, and clinicians for more than 10 years. OpenNotes works with collaborators around the country and now overseas to foster and evaluate the spread and implementation of shared clinical notes. We call these OpenNotes. We are funded entirely by federal and philanthropic gifts. So we are really excited about today's presentation. Think of the next hour as this crash course on OpenNotes. And in the coming weeks and months, we'll be providing more webinars around different aspects of OpenNotes. But today is the basics, the 101. We're sharing info with you in 3 short segments. So first, Dr. Kate DeRoche is going to cover 10 years of research in a few minutes, plus a tiny bit about a new federal mandate you may be aware of. Then we are going to share 2 short video clips from real patients talking about their OpenNotes experiences. And then finally, the main event, Dr. Sarah Jackson is going to share her experience and tips after 10 years of sharing notes at a safety net hospital with patients. And then we're going to go into Q&A. So that's what today looks like. So let's start with Kate. Dr. Kate DeRoche is the Executive Director of OpenNotes and the Associate Professor of Medicine at Harvard Medical School. She's a distinguished health services researcher with expertise in emerging trends in healthcare delivery. Kate, please take it away.
Thank you, Liz. I was just looking at our poll results, and it looks like roughly 3/4 of the people who are on the call with us today have never gone to an OpenNotes event before. So I'm going to give you the background. For you, all of you that are in that 26% that have, just bear with me because we'll get to the main event with Sarah Jackson as quickly as we can. So I'll just reiterate something that Liz said. So OpenNotes are really just when patients can easily read visit notes. OpenNotes, capital O, capital N, is our group. We are a philanthropically funded group who is focused on improving healthcare through greater transparency. And specifically, we focus on sharing clinical notes. We're funded entirely through philanthropy. You can see on this slide a smattering of our major funders, and we're located at the Beth Israel Deaconess Medical Center in Harvard Med School. We don't have an app. We're not a vendor. We don't have a server full of notes somewhere that we're mining for information. We simply are promoting the idea of promoting and studying the idea of greater transparency in healthcare through sharing clinical notes. I'm going to start out just with a quick reminder about why notes are so valuable to patients. So you can see here on this slide on what a patient typically sees, an after visit summary, which includes things like, yep, I'm still the same, here's my weight, and here's my vital signs, versus on the right, here's the note. And it has lots of information for the patients. It has information about follow-up care, what we discussed during a visit, and it's just a much richer source of information about what happens during a visit than that typical after visit summary is. So over the next few minutes, I will summarize 10 years of research and give you a quick snapshot on what's next for our group. So OpenNotes began in 2010 in 3 states, and there's a Seattle, Harborview Hospital in Seattle, where Sarah Jackson practices, so she'll be talking later. Geisinger, which serves a primarily rural population in Pennsylvania, and then our institution, the Beth Israel Deaconess Medical Center, which is an academic medical center in Boston. And the idea was very simple. We recruited a set of primary care providers and a set of, and we opened their notes to patients, and we surveyed them before and after the intervention. So you can see here, before the intervention, the physicians were concerned. It does not fully capture how clinicians felt about this idea. They were worried about workflow. They were worried about confusing and offending their patients. They were worried that their offices would be overwhelmed with phone calls and emails about things people were reading in the notes. And on the patient's side, patients thought, yeah, this sounds like it'd be a good idea, but I had no idea that this was even a thing. I didn't know that you wrote notes about me, so sure, we can give this a try. After the survey, the intervention ran for a year, and then we surveyed them in the post-intervention period, and the physicians on the whole thought this was fine. In fact, one of the remarks that we got was, are you sure that this is turned on? Because I'm not hearing from my patients the way that I thought I would. So most of them thought it was fine. It did not lead to an increase in their workload, either phone calls or emails. And all of them chose to keep sharing their notes with patients, even after being offered the option of turning it off. And on the patient side, they really liked it. Most of them read at least one note. Almost all of them said it was a good idea, that it helped them to feel more in control of their care, to do a better job with their medications. They reported sharing their notes with other people who were also involved in their care, like a spouse or an adult child. And we also found that the benefits persisted and in some cases were more likely to be reported by patients who we think of as traditionally underserved by the healthcare system. So patients who self-reported that they were from a racial or ethnic minority group, patients who had limited English proficiency or lower levels of formal education were more likely than other patients to report benefits from reading their notes. We recently, or somewhat recently, 2 years ago, went back and resurveyed at these same 3 sites. So in the intervening years between the pilot and this new survey, all of the sites opened their notes in virtually all of their ambulatory care settings. So we wanted to understand whether these benefits would persist when more patients were reading, and when patients were reading notes across a broad range of ambulatory care settings and specialties. And overall, we found that these benefits persisted. Patients still said notes were very important for taking care of themselves. Almost all of them said they understood all or nearly everything in the note. That reading notes helps them to understand their medications. About 20% found an error in their notes, and when we asked clinicians this same question, they also said about 26% of them said that there was a time when a patient reported a clinically important mistake in their notes. The clinician themselves thought that the mistake was clinically important. And we continue to see that these benefits were more likely to be reported by patients who had less formal education and limited English proficiency. And for clinicians, after 7 years, the majority say that sharing notes is a good idea, that it's helpful for engaging their patients. Most of them would recommend it to a colleague. Very few reported questions or concerns from their patients. Now, about a third say they spend at least somewhat more time in their documentation. We don't have a measure of what that somewhat looks like, but there is a brand new study out just recently that showed that the increase in time, that they measured it by measuring how long from when the note was opened in the EHR to when it was signed off on, and the increase post implementation of OpenNotes was just a few seconds. So it's a small amount of time. However, if clinicians are thinking about how they might write their note a little differently, if patients are reading it, then I think it could probably feel like more time, which is important. So since that early pilot, OpenNotes has continued to spread. We, on the strength of those findings and some very generous foundation funding, we've been able to really work at perfecting our own dissemination practices. So how do we spread best practices around note sharing to other healthcare organizations? And so we know of about 260 organizations that now share notes with patients. And among those organizations, 53 million people are signed up on their portals. So 53 million people across North America now have access to their notes. And this includes large and small organizations, rural and urban, and the entire VA. And an additional significant change since the pilot is a new public policy. So some of you may actually be on this webinar because you know about the new public policy. It stems, so it has its roots in HIPAA, which, while it's a very complicated piece of legislation, the simplest part of it to understand is it gave patients the right to access their medical records, so it starts there. Augmented by the HITECH Act, which incentivized organizations and clinicians to adopt electronic health records, and those electronic health records had to have a patient portal. And then finally, the 21st Century Cures Act, which was primarily about biomedical innovation, but did have a section in it focused on improving interoperability, or how data flows between clinicians and between organizations and patients. And in that legislation, there's a line that says that patients have to have electronic access to all of the information in their electronic medical record. So fast forward 4 years, and we get to the interoperability and information blocking rule. So that is essentially, this rule is the implementation of that portion of the 21st Century Cures Act. And it requires a greatly expanded set of information to be electronically shared with patients. And this includes progress notes, 8 different kinds of notes, including progress notes. It was set to be implemented in the fall, but was pushed back because of the COVID pandemic to April 5th of 2021. Lots of progress from an early pilot with 100 primary care clinicians in 2010 to 2021, where we will see that all organizations will have to share notes with patients. And so as we think about our kind of success that we've had with dissemination, we continue to think about, well, how can we do this? How can we implement this in a way that means that we actually get to the benefits and patients are really reading their notes? So we're still focused on best practices around implementation. We have projects focused on sharing notes with care partners, with how this affects how we can engage with vulnerable populations. What about mental health notes? That's a big issue with this new transparency. We have work on the bioethics of sharing, how sharing can improve patient engagement, patient safety. And finally, we have pilots focused on a kind of bi-directional sharing of notes with patients, where patients are actively asked to author a portion of the note before the visit. So lots of work left to be done. And I'm going to stop there, say thank you, and pass the mic back to Liz.
Thank you, Kate. Thank you, Dr. DeRoche. The next phase we're going to go into is share a couple videos, 2 video clips from patients talking about their experience reading their notes at both Beth Israel Deaconess Medical Center in Boston, as well as Harborview in Seattle. And If you've attended webinars before where videos are shared, there's always a bit of a gamble in streaming videos during webinars, but this worked in some small trials last week, and so we're hoping that the audio, at least today, will be clear, but we know the video may be a little choppy. In the first video, it's about 3 minutes long. It's a montage of 6 different people talking about their experience with OpenNotes. And then the second video is about 30 seconds. We'll hear from Marilyn Hong, who helps her sister, a non-native English speaker, make sense of her medical visits by reviewing their notes together. So Amanda, if you can queue up these videos, that would be great. And bear with us as we click between screens.
Wondered, what is he writing? What's he saying about me? And I think there's a kind of mystery that many patients feel about whatever it is the doctor is writing.
I want to be a partner. I want to really be on board with my health. I don't want to be in the dark. I don't want to have the doctors have access to things that I don't. I want to know.
Well, you can look at the comments that Bob writes down, and sometimes, you know, you agree with them, sometimes you don't agree with, but that's the way it is. And, you know, I know what's right for me, and Bob knows what's right for me. And sometimes they clash in that. And then Bob and I talk about it, and it works out. We work things out.
I think one of the not so apparent but real values is that people will share them with others. They will be able to have much better communication, much better conversation with their loved ones, with other professionals, because they have a written record that they can pass on, either by forwarding it or printing it out and showing it.
Last year when I was pregnant, I had gone to see my primary care for a checkup, and everything, thank goodness, was fine. But she did notice a mole on my back that she had asked me to follow up with at the dermatologist. But being pregnant, I forgot all about it. I remember a few weeks later, there was something nagging at me. And then I was reading through my notes, and I saw the notation that said, referred to follow up with dermatologist. So I did. I immediately went to the dermatologist, and she felt that it needed to be removed. I was so incredibly relieved, primarily. And I felt this sense of safety as well, because I actually had a hand in what was going on with my own health care.
Even though I'm really healthy, I know that the moment I don't take my pills, something could go bad. And I don't want things to go bad. Having it written down, it's almost like there's another person telling you to take your meds.
I guess I am somebody who believes that trust will be easier come by between doctor and patient if there's more candor and openness. OpenNotes is a cultural change. Doctors and patients and family members who know that there's a level of transparency will shift their behavior towards honesty and candor.
You and I used to share information when I would go to your office without OpenNotes. OpenNotes is just like the period at the end of a sentence, okay? It helps me understand what you're doing, because I didn't have major surgery, but I know what's happening with me.
It's about me, and I want to know what's going on with me. And that's the most important thing.
In some situations, she comes alone to the appointments, and I would like to know what the doctor said in case if she couldn't understand very well. And the OpenNote is there for me to teach me, for me to learn what was the communication between my sister and the doctor, what they say and what they recommend, and how can I help her in order to become safe and healthy.
Okay, thank you guys. And hopefully I made it clear ahead of time. We knew that the video would be choppy, but we were excited for those patient voices, those who actually read their notes, to be translated to you today in our presentation. So it's not just us talking about OpenNotes, but you're actually hearing from patients as well. So now we're leading into the main event. I always do a drum roll. Dr. Sarah Jackson is the medical director of the adult medicine clinic at Harborview Medical Center in Seattle, Washington. She's an associate professor at the University of Washington Medical School, is a board certified in internal medicine and addiction medicine, and has been engaged in patient care and research related to OpenNotes in a safety net setting for the last 10 years. We're excited to learn from her today. Dr. Jackson, please take it away.
Yeah, so next slide. I have been working with the OpenNotes group and on OpenNotes incredibly for I think over a decade now. And I work at Harborview Medical Center in Seattle, Washington. Harborview is a level 1 trauma and burn center, but it's also the primary care location for the safety net population of King County. And my clinic, the adult medicine clinic, is in one of those windows there. And we're a large teaching clinic. We have about 36 continuity internal medicine residents who have their clinics there. Medical students rotate through it. There's also at Harborview an HIV clinic, a clinic for non-English speaking patients, and another clinic for homeless patients. And when the OpenNotes original study first rolled out, I remember being at the clinic meeting where we discussed the concept. And I will say that there was a lot of very healthy skepticism about, well, honestly, some just thoughts that this was a really dumb idea, and that notes were for doctors and for doctors' communications to other doctors, and this would create all kinds of problems. So we, before the pilot began, oh, and I should add, our patient population is, we see patients with complicated mental and social conditions. We have a lot of patients with mental health and addiction issues, homeless, non-English speaking patients. So, and so we did some focus groups prior to the original study in the adult medicine clinic and also in the HIV clinic at Harborview. And just to sort of summarize their thoughts, the patients were able to imagine perceived benefits primarily in that they would understand their health care better. It would be more convenient for them to be able to see the information, that it would be empowering for them, and that it would improve their relationship with their provider. Their concerns were about privacy and people hacking into the computers. And then they were worried about whether they would be able to understand it all. They worried that the computer would replace their ability to actually reach their doctor, and they really valued that ability to connect with their own doc. And then very kindly, they were concerned that it would be a burden for their doctors. Kate's already kind of summarized the results of the larger study between the 3 sites, but I'm going to focus a little bit specifically on Harborview because the subgroup data from Harborview, because it is a safety net population and a little different from the larger group. But I think one of the big take-home messages is that patients in the safety net, just like at the other sites, after having had access to their notes, very similarly felt that they had more control, they understood their conditions better, they were better at taking their medications. So more similarities there. And then the things that we really worried about, that would be confusing, that they would be worried more. This was slightly higher than the other sites, but still really relatively small, 8% for those. And then I think the doctors also worried about patients being offended by things that they had written. And really a very small proportion of folks at Harborview felt like they had been offended by what they read. And then I think a very interesting piece is that in our safety net setting, it was over double compared to the other sites, the percentage, 42% compared to 20% that had shared their notes with either a family member, a caregiver, another professional. So they were interested enough to share that with others. And similar to the other groups, they thought it was an important factor for choosing a future doctor or health plan. And then the providers, who had been very concerned about what this would look like afterwards, after the study, really, they didn't, the visits didn't take longer. They didn't really spend more time on their notes. A fraction were less candid in their documentation. But generally everyone, patients and providers, wanted to continue having access, the patients having access to their notes. And then just a subset, because we did do this originally with patients who had HIV, because this is a sensitive topic, we looked at how these patients compare to patients that didn't have HIV, and basically it was the same as far as their perceptions of risks and benefits. And they also were more likely to share their notes with friends, health professionals, other doctors. It was like 38% shared with another doctor. And you can imagine patients coming from all over Washington for their HIV care and being able to share that information with their local providers would have been helpful for them. And then the HIV doctors, and there were a lot of them, were less likely than other doctors in other settings to change the level of candor in their notes. So that was good feedback. And then, so 2014, about 4 years after the study, UW, the whole system-wide, open notes to patients. Anyone who had an eCare portal access would be able to link and read their doctor's notes. And the process for that really was, of course, there's email, and then clinical leaders would meet at section meetings, department meetings, clinic meetings, sort of letting everyone know that this was happening. When we did it, we did not actively message this or market it per se to patients. I think that was because that there were doctors who were worried, if what's going to happen, when this goes live. And part of the information that was shared in those meetings, we had FAQs for patients and providers that were circulated. And then we talked about tips for providers about how to write shared notes, because this is a new skill. We learn in medical school how to do shorthand and all of these pieces, but how do you write it for patients who are going to read your note? And this is in this article by Klein et al. And I'll just briefly kind of hit some of the highlights for those, since this is a 101 session. Before a visit, we recommended that docs develop a clear template. We use Epic, so a template that is easy to navigate. I think is helpful for not only patients but other doctors and yourselves, and not one that's filled with a lot of added in information or note bloat. And then for patients that you really are trying to engage through the note, who you think this would really help to have afterwards, or in their care partners, letting them know that they'll be able to read them and why it might be helpful, that they can look afterwards and see what you all had talked about. And then this part about consider writing notes with patients. There's a lot of work that's going on with that. That our notes work that I won't go into in detail, but having patients be able to put information in from the portal about their interval history. And then this is just on a simpler scale, will often, as a patient is telling me a lot of stuff, I'll say, because I type notes, I'll say, well, let me make sure I'm getting this right. And I'll actually type it and say the words that I'm sort of summarizing as I put it into the note. And it that can help them to realize that information is going in and in what form. And so during a visit, I think it's helpful to just think of it as a communication tool, not so that it becomes this complicated process, but just it's an opportunity to really share this information in a clear way. Sometimes I know in visits, things can go pretty tangentially, and when I write the note, I kind of make it clearer for myself. And this, I think that can be helpful for the patient also. And I think people worry a lot about sensitive issues like, could this be cancer? Are they going to talk about my cocaine use, obesity? And obesity, I'll just mention, is sort of a hot button phrase that I think patients do often. They don't feel good about seeing. But I think these are things that really do. They're thinking about and being clear about it in the note and connecting the pieces so that they understand what you're thinking, I think is important. And then this is something that I think, I think most docs do a lot verbally, really being cheerleaders for patients. is something that you do during the visit. But you can also, I do think this is something that I have changed since OpenNotes, is really putting that in there. It has done a great job despite all of these barriers to, with X, Y, and Z. And that placebo effect, I think, can be beneficial. Also during a visit, being objective and not judgmental. We definitely get, in having been involved in these focus groups, very specific comments about things that doctors have written about their about patients or loved ones that they have taken offense to. And these are a couple of examples there. And often they're words that we've learned in a non-pejorative sense, like refused as opposed to declined. But there are subtle aspects to that make the patient seem like they're that have connotations. And I'll just share my example of that. My husband went to see a dermatologist and got his OpenNote back, and in the physical exam, it described him as a middle-aged, semi-athletic male. And this was a visit for his rosacea. So that was, and it was pretty devastating to just see that, and whether that's accurate or not is a question. But whether does it really need to be in the note is something to think about. And then of course jargon and abbreviations. And I will just say, number one, patients realize that the notes are for doctors. They totally understand if the language is going to be above, about 8th grade reading level. So it's fine to put those things in there, especially if it makes your note writing easier. But if you have a way to not use abbreviations, I think that also can help across specialties. And as I get older in the practice of medicine, they change these abbreviations. And so I think it can help even with provider communication to avoid using those. And of course, the classic one is SOB, shortness of breath. Sometimes for patients that can be off-putting. And then after a visit, of course, there are lots of reasons to have your notes done in a timely manner. And then I think, you can use it as a tool. When the patient comes back, you pull up your last note and say, did you get a chance to look at this? How did it go with X, Y, and Z? And then you can get feedback about what they thought about the note. And then amendments. I'll just throw in here that over the last decade, I've had, I think, 2 patients request amendments. One is a patient who avidly reads her notes and sends a lot of e-care messages. And I had misrepresented a piece of her social history, which made 0 difference. And so I went back and I changed that. And then the other time there was a gentleman who asked me to change something that I really thought would be inaccurate. And we discussed it, and I did put in an amendment which just said, so-and-so feels that this is, not correct, but because of X, Y, and Z, this is what I'm putting in here. So I think you have to be honest, and that process, when there are things that are inaccurate, it's super helpful to have patients who catch it and you can change for future users of the notes. And so we were also interested, so after the entire system went live, we went back to our vulnerable clinics, our adult medicine clinic, Madison clinic, and we did more focus groups. And before we did this one, these were people who had access. Before the original focus groups, it was sort of this hypothetical thought exercise. This was after they'd had access to OpenNotes for years. And because it was the pilot and after the system went live. And right before the focus group, we had them read their last primary care note. And then, so we captured a little quantitative data and then did the focus groups. And they thought 89% found that the note content was helpful. Similar to the other studies that Kate mentioned, about 20% found some inaccuracies. And about a quarter felt that there was too much medical jargon and that it was too long. But as far as the focus group themes, they also appreciated having that more detail. That was one of the themes, that they would rather have more detail than less. Another theme was if the content was confusing, they would rely on the provider to explain that confusing content. And that sort of circles back to that confusion and worry. When people feel that when they read their notes, they can always go back to their provider and get more information. And then the inaccuracy pieces, they particularly found those in the heavily templated notes, which we definitely had. I think we were sometimes at the mercy of our vendor sometimes with our note templates. Yeah, and a couple of quotes. Oh yeah, give me all the information because I'm going to look it up otherwise. So at least here it is. This is more bulk, more data. I think it's good. And then this one about families. This is good information to have, and it would be good for my kids to know and have. I don't have to explain every detail to them. They would just know what is what and how to go about it and take care of it. And I think this piece about being able to share with loved ones is really a key component of OpenNotes. Next slide. And I'll just make a few comments about COVID. So 9 months of COVID pandemic. Our institution, just like everyone, has really had a huge push to try to leverage as much telehealth as possible. And I'm just showing here that for Harborview, which of course is our safety net population, the percentage of folks a year ago who had their portals active compared to this year, it's still less than half, but there has been a large increase. When COVID occurred in the spring, we had a lot of medical students who couldn't see patients, and so they came up with a pilot project to reach out to our patients who we were trying to reach by phone and try to get them set up for Zoom, the audio-visual visits. And as they were doing that, they were kind of collecting data on what some of the barriers were for our safety net folks. And what they found was that about a quarter of patients just did not have the technology or the Wi-Fi access or enough data on their phones to really be able to engage this way. And for folks that were 50 and older, it was about half of patients that just weren't able to do this. And so I think that this is just, with COVID and technology, this is going to be an important thing for us to work on to decrease the inequity of care that we're able to provide. And it may mean human beings actually helping in addition to the tech component. One other piece about COVID that I'll just mention, we're all, as doctors, we think about OpenNotes from the perspective of the note writer, but we're also all patients. I'm a patient in this system, and I can read my notes, and so that's been beneficial. But also, particularly during this COVID pandemic, I have my parents, I'm in Seattle, my parents are in Kentucky, and they both now have COVID. And luckily they've been at home so far. But if they were to go into the hospital in Kentucky, it would be so amazing if I was able to connect via a proxy server and see what was going on and be able to relay that to my siblings. And so there are benefits for docs across multiple. We're also patients and caregivers. Okay, so just to summarize, after a decade of using OpenNotes at Harborview, it has really not been a burden at all for physicians. I don't think about it. I've made some subtle changes to my notes, but it did not break anything. I do think it's been, for patients who have been able to engage and use it, the feedback has been really positive. I think it's the fact that their doctors trust them enough to let them read their notes and engage with them about their notes is really huge. The relationship building and just having access to their own health information is very valuable to them. And there have been UW-wide increased note amendment requests, and I think particularly in the case of inaccuracies in the records, having someone who is an avid reader and deeply invested in making sure that things are accurate, this is a really big positive of OpenNotes. And then I think looking forward, particularly in the time of COVID, being able to support patients in instruction and utilization of these electronic tools is really important, particularly in safety net populations. Thanks.
Thank you. Thank you, Dr. Jackson. That was incredible. I'm sure everyone who's tuning in is really appreciating the stuff that you have to share. For everyone tuning in, we're now moving into the Q&A phase of the webinar. So make sure you go to the questions area of the chat box and start inputting your questions. Moderating Q&A today is Deb Wachenheim, our Assistant Director of Research Dissemination, OpenNotes. And while you're inputting the questions, I do want to plug our upcoming webinars and office hours. We're going to be focusing on the following months around OpenNotes and pediatrics, mental health, oncology. I'm forgetting the rest, inpatient notes and OpenNotes. A lot of stuff is coming up. So, and Amanda, thanks for sharing that slide. So if you're on our mailing list, you'll learn about those things. So, and then we also are at the end of this week on Friday, we're going to be doing open office hours with Dr. DeRoche and Dr. Jackson, where it's just webcams and asking as many questions that you want. And I know in the chat box, Deb will be sharing the link there. So Deb, what questions are we getting?
Okay, so there was a question about, did you experiment with note sharing in languages other than English? So if either or both of you could touch a bit on what you saw for patients whose first language is not English.
So in the formal pilot study and the follow-up evaluations, we have not experimented with notes written in other languages, primarily because the medical record is written in English. And my greatest fervent hope is that as the app market starts to expand, as people start to get the ability to access their notes through third-party apps on their smartphones, that there will be translation, that AI and natural language processing will help with translation, and that can be built into apps. We know now that the sort of standard Google Translate type of algorithms are not good enough for notes, that they introduce serious errors. But my wish is that could happen, that will happen, and we could think about things like, well, how about if we just start with technology that translates the care plan as the first place to start, because that's going to be maybe written in less technical language than things like than other parts of the note. But there are plenty of places now that are doing this among populations that have limited English proficiency. In particular, Mount Sinai has done it with their Spanish-speaking patients through using Spanish Navigator to help patients sort of learn how to work through the notes. But there hasn't been a lot of other work in that area.
And I would just add, yeah, we haven't done it with actual language translation, but we have a lot of patients who speak other languages, and often we try to leverage their family members, grandchildren, caregivers who do speak English and can use the proxy portal to help with that. But that would be a great future event.
Another question was, has this been studied only with physicians or NPs and PAs as well?
That's a great question. The initial pilot was done only with primary care physicians, but over the intervening years in the 3 sites, as they opened notes across all of their ambulatory care settings, now it's now NP notes, PAs, nursing notes, all kinds of notes can be read by patients. So our more recent clinician survey that I showed you, that includes PAs and NPs.
I'd like to share that.
And they tend to be about the same as docs. their attitudes tend to be about the same. I would say maybe NPs are a little more positive, but on the whole, everyone is fairly positive. So there's small differences.
And if you're looking for any of the research that Kate is referencing, we just released a new tool on the OpenNotes website. It's a research search tool. I'll post the link to that in the chat box, but it's essentially opennotes.org/research. And then you can kind of filter by what kind of research you're looking for.
Another question was, is the patient portal the only way that patients are allowed to receive their notes? Can you further define the electronic availability with OpenNotes? Does that mean I can send them securely in email?
So the regulation doesn't state that patients have to. It doesn't state that patients have to log on and get their notes by clicking on a notes tab in the portal. You can send the notes electronically through the view, transmit, and download function, or you can allow patients to see them through the notes and visit tab. And I suppose you could also send them as secure messages. I mean, that's HIPAA compliant because it's behind your firewall. And if that's what a patient requests, I don't see why you couldn't do it that way.
Can you speak about how behavioral health note sharing has been received by patients and physicians, especially any rupture in trust between clinicians and patients, and any special considerations as an agency moves towards sharing these behavioral health notes?
Sarah, do you want to talk about that, or do you want? I can tell you what we know about what we know from research, from our research, but you may have clinical experience with this.
I can give anecdotal information. Because I certainly take care of folks who have used the portal and have had significant mental health issues. I would say over the last 10 years, I've had 2 patients who have become concerned. I think, in part because of their mental health condition, particularly concerned about what was written in their notes. And I think my take on that really is there are other things that they were concerned about also. Often if they, if there's something in the note, there's something else that would have happened that they would have had issues with. There was, and Kate, you may be getting ready to talk about this too, after the 7-year follow-up, there's a paper by Klein et al. Where they looked at patients that had mental health diagnoses, about 400 patients, including bipolar and psychotic disorder diagnoses, and compared them to the other respondents. And actually, there was not that much difference in their perceived risks and benefits. This is patient reported. They actually statistically significantly felt that they were better at taking their meds and remembering plan of care than patients without mental health disorders, and were slightly more likely to worry more about their notes. I don't know if that, yeah.
And there's also, we did a pilot at the Beth Israel where social workers shared their therapy notes with patients, and it was overall showed positive results. The patients liked having access to the notes. The social workers, despite initial concerns, felt like it was an overall positive, and they reported that it changed the way they thought about their notes, in that the notes became another tool in their sort of therapy toolbox with patients. And then finally, I'll just talk for a minute about the VA. So at the VA, all notes are shared, inpatient, outpatient, psychiatric, all notes. So you could have a patient who is inpatient for a psychiatric reason, and that patient is reading their inpatient notes during their stay. And so they've done quite a bit of work on this. And one area where they found that it could be challenging for patients to read their therapy notes is around post-traumatic stress disorder. So rereading, if there were sort of all the details of the trauma was in the note, that could be triggering for the patients. That was the one area. And they've actually, the VA's done they have a whole educational module where they to help providers kind of get ready for this change and maybe make a few changes to their notes in order to cut down on the number of problems they might have run into. But overall, the VA's experience was also positive.
I do med oncology and palliative care. I ask patients if they want to know the prognosis. Even if they don't want to know, I include it in my note for the day to share with colleagues. How should one deal with this? One concept I have heard is to tell the patient it will be in the record and suggest they not read the note. And then we did have another question just broadly asking, what's your experience with oncology open notes? So if anybody wants to take both of those.
Well, I'll just make a quick plug around palliative care, and then I'm going to let Liz talk for a minute about the oncology, about what we know from our oncology data. We did do a webinar recently with Christian Sinclair. The whole thing was on palliative care, on doing open notes in palliative care. He did address this issue. I would suggest if this is your area and you want to dig into it, that video the video of the webinar is available on our YouTube channel. And Liz is nodding, so that means I'm saying this correctly. So I would suggest, I think your thought about you need to document it and you need to be open with the patient that this is going to be in the document and you will have access to it, but you don't have to read it, would be sort of his advice as well. But I really recommend, he did a terrific job, so I really recommend that video.
Yeah, so Dr. Christian Sinclair, palliative care doctor at University of Kansas Cancer Center, he presented in October. We've got it online. He was kind of like there is no research on open notes in palliative care. So he's kind of this first person to really be doing this and reflecting on it. And his advice, like Kate said, was, in palliative care is about communication, about serious stuff, sometimes tough stuff. So to talk to patients, like, I'm going to be talking about this in your note. If you want to know about it, you're welcome to read it. If you don't want to know what I'm saying in your note, you don't have to. So it was really nuanced communication stuff that lends itself well to open notes. And when I'm done talking, I'll post a link to where you can find that recording in the chat box so that you can easily get to it. As far as open notes in oncology, we just published something in Cancer Cell, and I could post a link to that in the chat box as well. And it was looking at the open notes after 7 years survey data that we did just a couple of years ago. In oncology specifically, 3 sites that have been sharing oncology notes with their patients. And what was interesting was we were comparing clinician views of open notes in oncology and then patients with cancer diagnoses in oncology. And clinicians were like, hey, it's okay, open notes is all right, sharing in cancer care. But patients really love seeing their notes in cancer care. If you think about it, folks who are dealing with something serious, they're invested in their health. They want to know what's going on. And they're actually more likely to read more notes than other patients, maybe because they have more notes and more visits throughout the year, but they also feel like reading those notes helps remind them of what happened in that conversation. Sometimes you're talking about serious stuff, so reminds them of what was discussed and also helps prepare them for the next visit. So they might be reading their note to go, what did we talk about last time? Oh yeah, this is what we said. So, there's clearly a need for more research into open notes in oncology. And in this series of webinars we have coming up in the next few months, we're going to have one specifically on open notes on oncology, featuring folks from Memorial Sloan Kettering and City of Hope Cancer Center, as well as a patient advocate. So that will be a fun one. So keep track with us and we'll let you know when that's happening.
Has there been an instance of a malpractice case initiated as a result of patients having access to medical record information?
So we were just looking 2 weeks ago so our insurer, Crico, has been tracking this issue. And so we were just looking at their data. And so for the Harvard hospitals, which is Crico's the insurer of all the Harvard hospitals, over the 10 years since we began open notes, there have been 0 cases that are related to a patient having access to something in their note. And that, I think, is not surprising when we think about the data or the studies around apology and open disclosure of errors. So we know from that work that malpractice, having a malpractice claim filed, is often the result of a breakdown in communication. And the family or the patient feels like they cannot get information about what happened to them or what happened to their loved one. So greater communication, more open communication is actually preventive against malpractice claims. And because OpenNotes is really all about better communication, all of the data is right there for the patient to see. While CRICO still won't yet let us say it prevents or it's a preventive against having a malpractice claim filed, they do let us say that it does not increase the likelihood that that will happen.
What are our obligations to edit when a patient requests?
So your organization should have a process in place already for what happens when patients identify or request an amendment to the record. And I would just suggest you go back to your, whatever your organizational, whatever the protocol is in your organization. So at the BI, a patient might write and say, hey, this is wrong. They can either, the clinician can work with them around an amendment, or they can work through patient care services, but there is a process. And I would just suggest that you review your organization's process. And Liz is giving me the heads up. So
yeah, we're at the last 30 seconds. I should have been paying attention, but I was putting links in the chat box for folks. So I want to respect everyone's time. We all want to respect everyone's time. First, I want to thank Dr. Jackson, Dr. DeRoche for being the experts on today's call. Hopefully you all will win, and thank you for paying attention today and joining us. I mean, stuff is busy out there. You're all dealing with COVID and caring for people, so thank you. You will receive an email with the link to this recording, a link to the slides. And I hope some of you can join us for our office hours on Friday, where we're going to dig even more into more questions, more nuance, and more open dialogue about what you may know, or we can all learn from each other. Let's see here. Any unanswered questions that Deb is tracking from today's conversation, we will also bring up again in office hours. And I think I've answered all the questions you might need to know as you log out today. Please visit opennotes.org. We've got a ton of resources and toolkits specifically around OpenNotes in communication with patients, OpenNotes in pediatrics and adolescents, OpenNotes in mental health, and on and on and on. Dr. Jackson, did you want to say anything before we end today's webinar, or Dr. DeRoche? Putting you on the spot.
Just thank you for taking the time out of your, I'm sure, what is a very busy day to come learn more about this.
Absolutely.
Yeah, and I would just echo that. I know with COVID going on, there's a lot of stuff on people's plates. So thanks for your participation.
Absolutely. Thank you again, Dr. Jackson. It was great to hear from you.